So this case is a thoracic stab wound. I know that starts kind of vague, but I didn't want to kind of ruin the surprise. So let's see if it'll let me advance here. There we go. I don't have any disclosures of interest. So the case is a 28-year-old male who presented with multiple stab wounds to the chest. He had a right upper chest stab wound that was supraclavicular with pulsatile bleeding and a non-palpable upper extremity radial pulse and a left upper quadrant stab wound. He had evidence of hemorrhagic shock with tachycardia to the 110s and 130s. He was hypotensive to the 70s to 90s. And a VBG was notable for a base excess of -12, and a pH even on that was 7.1. Just kind of for anatomic reference, these were the two areas that had the stab wound. So you can again see there's a right sort of supraclavicular stab wound and a left upper quadrant stab wound. So, so I'll start off early right now, which is, you know, what would be everyone's approach from this point? A patient with hemorrhagic shock and those two stab wounds.
Let's go to Portland first, Dr. Kassim.
Good morning. So this is a young man who is probably compensated from his hemorrhagic shock, yet he's in shock at this moment as we speak. And he has two stab wounds, one in the box, one outside the box. So I'm thinking, which of these stab wounds is going to kill him very quickly? So I'm going to be concentrating on the one near the box. So the first thing I would do would be I'll put an ultrasound on the precordium to see if there is any cardiac tamponade. And having established he's still got heartbeat and plus or minus cardiac tamponade, then from there I will move forward with the other things. Thank you.
Thank you, Dr. Kassim. Let's go over to Iraq. Dr. Untrat?
Yeah, so I concur with a lot of what Dr. Kassim said. I'd start with the ABCs, and I missed again the systolic blood pressure was what now, Dr. Jain?
It was in like the 70s to 90s.
Yeah,
blood was started immediately, obviously, but
right.
Yeah.
So he's tachycardic and hypotensive. So he's lost half his blood volume. So he needs volume resuscitation, and airway needs to be protected. I agree with doing an EFAST immediately. He might need bilateral chest tubes, maybe not, and need to rule out as part of the EFAST cardiac tamponade. And then the issues are going to be likely transection or partial transection of the right subclavian artery, and depending on the trajectory of the knife, whether stab up or down, it's either intra-abdominal or intrathoracic on the left side. So I think the EFAST would guide you to the right side of the chest, and if there's any delay in doing the EFAST, I would certainly put a chest tube on the left side, looking for blood, and that would be my first step right there. Bring his blood pressure up as part of the resuscitation. Thank you.
Thank you, sir. Sao Paulo, Dr. Calais?
Yes, I agree with the comments. I believe the patient in shock, and they need investigation start with the investigation for the source of the shock. Maybe on the box, as Dr. Kassim says, maybe a knife can go up and hit the heart, or can go to the abdomen. I don't know. So I believe this patient need IFS quickly to see the pericardial window. You have obvious signs of injury of subclavian veins or arteries in the upper left, in the upper injury. In this situation, you can start start control access venous, maybe orotracheal intubation for protect airways. Sometimes you need to put a chest drain. But in these situations, when you have supraclavicular injuries and can blending, you can put a Foley catheter through the injuries and insufflate the balloon and push the balloon through the size can tamponate the injuries of the artery. Can be bleeding for external and can be bleeding for pleural cavity. So sometimes you can control the hemorrhage using this technique. So that's the way I can start. Thank you.
Thank you, Dr. Khaled. Let's go to Dover. Dr. Alex.
Yes, I agree with all the comments made. So basically going through the ABCs, you know, if I would pay attention to the trachea, make sure trachea is midline. If it's not midline, then I'll be suspicious of tension pneumothorax and prepare for chest tubes. That would take care of breathing. On circulation, it's a great idea to put a Foley catheter and just control the bleeding for the supraclavicular stab wound, and then the pericardial fast, see if there is any signs of tamponades. I would also start massive transfusion protocol, have adequate IV access for that, and then that's it for now. And get a chest X-ray. Thank you.
All right. Thank you, Dr. Alex. In Trinidad, Dr. Ali, your comments, please. You're muted, Dr. Ali. Check your, okay, good.
Sorry? Can you hear me?
Yes.
Yeah. So I said, I presume you have checked his airway, it's okay, and his breathing is fine. Has he got any difficulty with air entry on either side?
No, I mean, you know, other than the fact that he has some moderate distress from the hemorrhage, I mean, he's protecting his airway, and he did have bilateral breath sounds.
His breath sounds are equal on both sides.
Mm-hmm. Yes, they are.
Yeah, and is his JVP up at all?
I'll be honest, in the chaos of the room and what ultimately transpired, I did not, you know, we did not see what the JVD was at that point.
Because there are two things I'm concerned about. One is hemorrhage. You said there was pulsatile bleeding, and I presume that's from the neck wound.
Correct,
And the
that's
other
from the
thing
neck
is
wound.
the location of the stab wound in the costal area, subcostal area, that could be in belly or abdomen or chest. And people are thinking about pericardial tamponade. Those are all possibilities. But I think if it's pulsatile bleeding in the neck, that takes priority right now. And the ultrasound will tell us whether or not he's got a hemopericardium at the time. But I think my major concern right now, if his airway and so on is okay, he got 2 large wires in the Foley catheter, is to find out whether this pulsatile bleeding requires something urgently in the form of intervention to stop the bleeding.
Thank you very much, Dr. Ali. And Dr. Rattan in Miami.
Yeah, I think colleagues covered just about everything, so not too much to add, just some clinical pearls. I think that you know, in addition to using the EFAST to rule out cardiac tamponade, I'd also want to interrogate the left chest in case it's decompressing through there before I felt fully comfortable ruling out a pericardial injury. And then, of course, if there is blood, then plan that a subxiphoid pericardial window may be needed. Though, honestly, with the hemorrhage and the shock and the location of the injuries, if my plan for the OR would be, you know, prepared to do a median sternotomy for proximal control, assuming that the subclavian's injured, or you may need to extend to the neck if it's a, you know, low carotid or something like that. And the only other thing I would mention is with the balloon, if you have a bit of distance to travel between where you're placing the balloon and your operating room, even with a Foley catheter, you know, they can be kind of floppy, and you've got to really sort of hold someone accountable to holding that completely in place as you're traveling, especially if there's some bumps or thresholds you have to cross. Sometimes clamping it to the person if the person's already asleep can help stabilize it. But getting the balloon in can sometimes be easy, but then it's if it gets dislodged, that can be a problem as well. And sometimes too, we've had trainees just kind of ride the bed with their finger and compressing against the clavicle if it's a clear enough injury. But but otherwise, the general clinical steps, I agree with what everyone said.
Thank you, Dr. Rattan. Good morning, Dr. Super. Do you have comments, sir?
Good morning, Gary. I agree with all the comments, and I think that the patient needs to be transferred to the OR after we stop the bleeding. I think the easiest way to stop the bleeding in this patient is by digital compression. And I don't have experience with Foley catheter putting in the supraclavicular wound, but I have seen lots of pictures. And this patient, I think, after we compress the wound, give him some fluid to raise the blood pressure a little bit, and check the pericardial view of the thoracic stand to rule out tamponade. I think he needs to go to operating room as soon as possible. Thank you very much.
Thank you, Dr. Super. Any other comments before we return to Dr. Sumeet? Okay, back to you, Dr. Sumeet.
Yes.
Thank you everyone for
Sorry.
Oh, sorry. Yes.
I'm sorry, Dr. Zaz?
Yes. Hi. Good afternoon from our area. Good morning from your area. Actually, it is an interesting case. I agree with what all you said about that, but I have some concern. Actually, I will do EFAST if it is positive for cardiac tamponade. Sure, I will go to for sternotomy and for cardiac. But other than I have to push the patient to OR after start to IV line, I will start damage control resuscitation. I just do compression of the bleeding side, and I push the patient to OR. I might start with pericardial effusion positive, I mean EFAS positive. I will start from sternotomy. Otherwise, I will start, it is obvious that right subclavian is injured because right external, right upper limb is not palpable pulse. I will start from that to control and to manage my incision. Thank you.
Thank you, sir. Okay, back to you, Dr. Sumeet.
Okay, so thank you all for your comments. I think it's very interesting because a lot of, I think what the initial steps might be also will depend on how close your OR is and how quickly you can get them there. Because I think everyone more or less agrees that we have a penetrating injury, one with obvious hard signs for vascular injury that seems to be like at least at the time appeared to be a proximal subclavian injury to the right side. So, so at Ryder, our ORs are very close, so we actually did not proceed with an EFAST or a chest X-ray or anything like that, and didn't place chest tubes at the time because we basically just took him straight to the operating room with the plan for sternotomy, thinking that if he did have tamponade, we would be able to take care of it with the sternotomy anyway. And if he didn't, then we would still need it to get proximal control of the subclavian for this, for what appeared to be a right subclavian injury. So he started on massive transfusion protocol and was taken directly to the operating room where sternotomy was performed and we obtained proximal control. I forgot to note here, the pericardial sac was opened and there was no pericardial effusion. And then it turned out that the injury was to the axillary artery. So the stab wound seemed to direct a little bit away from the middle of the chest, which obviously we could not appreciate at the time. So an additional infraclavicular incision was made and extended to the axilla to expose the axillary artery and vein. The vein was injured and so it was ligated. The artery was debrided and then an interposition graft was done, after which pulses were palpable. And chest tubes were placed in the right chest and mediastinum, mostly because we incidentally entered the pleura on the right side during the sternotomy. The left upper quadrant stab wound was explored and did not violate fascia, so nothing else was done, no laparotomy was performed. So this is a picture of the field. So this is the arm is kind of extending up this way. So here's the two ends of the axillary artery after debridement. And then this is the artery after placement of an interposition graft. So, so after this, he was extubated a couple days later. He had complaints of right arm weakness and sensory deficit, so we felt that he probably had a brachial plexus injury. On post-op day 4, he developed new onset tachycardia and hypoxia. and he was found to be using accessory muscles, and so we were concerned about redevelopment of either tamponade versus PE. So an echo was done. There was no significant pericardial effusion, no heart strain, but the CTA did show a pulmonary embolism, which you can see here in the right upper lobar pulmonary arteries. So at that point, he had a left chest tube that was also placed for a large left effusion. An IVC filter was placed, and therapeutic anticoagulation was started a few days later. On post-op day 9, he was extubated to high flow nasal cannula, and on post-op day 11, a right chest tube was removed. And then we had the following follow-up X-ray. So, so my question here is, again, what do you guys think is happening here, and what would be your next step? This is a completely new development on the right chest, by the way.
Over, Dr. Alex, your comments, please.
So I see that he has a pigtail on the right chest. I see there's something going on in the upper portion over there. Almost looks like effusion that's not drained, maybe hematoma, just kind of coating the top of the right lung. So first of all, with the PTFE, I noticed in the picture it wasn't a ring, PTFE. Probably, that may be better in terms of kind of holding for like axillary artery. In terms of the IVC filter, I was wondering why he had an IVC filter placed. Were there any signs of bleeding before? Was there frank blood in the chest tubes that were placed? I'll probably re-image this this patient with another CAT scan with IV contrast to get more information.
So just to answer your questions really quickly, he remained having palpable pulses during this entire time period. So our suspicion for a major problem with the vessel was minimal. I mean, again, this occurred pretty much immediately after the right chest tube was removed. In terms of the IVC filter, at the time, he was still having he had a mediastinal drain, which was later removed, but he at the time, he was still having a little bit of bloody output from that drain. It was very slow oozing. He never really dropped his hemoglobin significantly or anything like that, but we were concerned about starting anticoagulation, at that moment, and so that's why we decided to get the IVC filter. That being said, literally 2 days later, at that point his drain had dried up and been removed, and so we felt comfortable starting anticoagulation at that point. So it was not much of a delay, but given the timing of it, obviously, in hindsight, it seems a little silly, but at the time it seemed we weren't sure when we would be able to start anticoagulation again.
Okay. So I would like to re-image this and get a repeat CT with IV contrast and try to find what's going on there and get more information. Does he have clinically pulses on the right upper extremity?
He does, yes.
Okay.
Palpable pulses.
Okay. Thank you.
Thank you, Dr. Alex. Bangkok, Dr. Sumba, your comments, please. You're muted, Dr. Sumba. Thank you.
Now he seems to have a respiratory insufficiency after the operation, and he's young, so we have to try to find the cause of the breathing problem. First, we can obviously see the collection or hematoma on the right upper chest. This may be clot pneumothorax or extrapleural hematoma, and it should be evacuated either by interventional radiologist or by thoracotomy. But I prefer to ask the IR to drain it for us first. And secondly, he doesn't seem to breathe very deeply. His lungs are quite small, and from the injury he had, he may also have a phrenic nerve injury on the right. And if possible, we should work that up maybe by using fluoroscopy and check his diaphragmatic movement while he is breathing. And that those are things I would do for this patient. Thank you very much.
Thank you, Dr. Supa. Let's go to Trinidad. Dr. Ali? You're muted, Dr. Ali.
Did you mute me?
Yes, sir. I'm sorry. There was a lot of
Okay.
background noise going on
Right.
there.
I'm trying to control it here. I'm sorry about that.
Oh, no
Anyway,
problem.
I'm concerned about the indistinctness of the left hemidiaphragm. Has there been any concern about that, decreased air entry or anything like that? And the lung volumes are generally limited on both sides, as was mentioned by Dr. Supa. So basically, I think the hemorrhage seems to be controlled, but he developed a pulmonary embolus, and I'm worried about that left hemidiaphragm being indistinct. Has
So
the stab wound penetrated the diaphragm? You said the fascia was intact. I presume it probably didn't penetrate into the chest.
Yeah, so this was more than 10 days later, and we knew that he had an effusion. So you can see over here, there's a chest tube on that side. So I think that indistinctness on the left hemidiaphragm is just residual pleural effusion on that side.
What was the pleural effusion from?
So I presume, so later, like after this day, because the chest tube was placed, I think 1 or 2 days before this. After this, we got cultures back that showed that he had an MSSA pneumonia. So it was probably a parapneumonic effusion on that side.
I don't have anything further to add at this point.
Thank you very much, sir. Sao Paulo, Dr. Calais, your comments, please.
Yes, I think in these patients we put the chest tube on the left, on the right, as I think is in the pleural cavity. You can see T margins, hematoma, or collections in the upper of the right side when you put a stent in the axillary artery. So in this size, this may be problem with pseudoaneurysm or some link of the stents can discharge the pleura from the thoracic wall, and maybe this image maybe represent. Sometimes in these situations, I think it's an image. You need to see an angio CT to see the neck vessels if there is a problem of complication of the stent in this area. That's the way I start to think about.
Thank you, Dr. Calais. And let's go to Iraq. Dr. Nuntrak, your comments, please.
Yeah, so this seems to be a semi-upright or supine AP film, and the lung volumes are small without bilaterally without any apparent reason. He didn't have a laparotomy, no thoracotomy, and he's a young man. So why small lung volumes? And on the right side, the pigtail catheter, I don't recall any history about when it was placed and why, but apparently it's not draining whatever that pleural thickening is, which is either effusion, hemothorax, or empyema, or perhaps it could be related to a possible pulmonary infarct from the pulmonary embolism. But and I agree that one of the others commented that you would do a CT with contrast to help to sort out the differential diagnosis. But about that pigtail, when was that placed and why?
So, so sorry, I think I might have posted the wrong image on this one. I meant to put the one that, there was one without a pigtail, which showed this exact same picture from immediately afterwards. This pigtail was placed in response at night to this decrease in loss, or out of concern that it was a significant effusion or, pneumothorax. But the pigtail did not return anything as was expected.
Right.
So I think a lot of, sorry, continue.
Right. Oh, okay, I get it. So, and then also about the possible phrenic nerve injury, I think this is more of a lateral stab wound. So, and the diaphragms in this case seem to be at equal levels. So I suspect probably the diaphragm, if you query it with the ultrasound, probably was, in this case, was not denervated. And in any event, that wouldn't explain why the small lung volumes bilaterally. And but anyway.
Yeah,
I'm sorry, go
just
ahead.
as a quick comment on the small lung volumes, he was kind of a bigger man who was not especially initially, really participatory in terms of like getting out of bed and using incentive spirometry and things like that. So I think the low lung volumes were primarily just related to that, as opposed to a, you know, like direct pathologic cause. So
Okay. Okay. Yeah.
Miami, Dr. Rattan?
Yeah, I agree with most people. What I see there on the right side is what concerns me for an extrapleural hematoma. So I'd want to get imaging to rule out a pseudoaneurysm from the repair. Though, yeah, again, the differential would be that could be pleural, though it sounds less likely. I also see, you know, I'm sure that this is an APX ray taken in the ICU or something, but, you know, there's this wide mediastinum, and both the lung fields look hazy. So I would also probably want to get an echo, and then also wonder if, I don't remember if I heard, but, you know, if there was a drain left on the way out from the median sternotomy or not, or, you know, any concern for pyopericardium or any other sort of pericardial effusion. So I would get imaging for the graft to rule out pseudoaneurysm, and an echo to look at any elements that could relate to heart failure.
Thank you, Dr. Rattan. Let's go to Portland before sunrise for Dr. Kassim's comments.
Yeah, you'll be seeing the sunrise any minute now. It'll be spectacular. Anyhow, so Dr. Samir, you told us that you ligated the axillary vein,
correct, yes.
and why did you do that?
It
Was
was
it
very
bleeding?
badly. It was very badly injured. Yeah, at that point, both the
Okay.
axillary artery and vein were injured.
Right. So you, by the time you approached this and you got the axillary artery isolated and you got clamps on both of them and you're contemplating putting in a PTF graft, how much blood have you used by then?
That's a very good question. So he had received somewhere in the order of 30 units of blood and a similar amount of FFP, platelets, et cetera, as the massive transfusion had been going. So
Right.
he had a significant amount of blood loss at that point.
Right. So you have had literally a massive transfusion that he's received by then.
Yes.
And did you contemplate putting in a shunt in there, because you're now in the realm of damage control?
So absolutely, we did contemplate putting in a shunt. I think what ended up happening was that once we found that it was this isolated injury without any other injuries noted, and once we got control, he physiologically recovered in the OR, pH started getting better, didn't need to give him as much in the way of transfusion, et cetera. And this was after the vein ligation. So the ligation kind of came, like we clamped the artery, the ligation came first, and then we sort of reassessed what our field looked like and what the patient was doing. And it seemed that he was improving enough that we could do the definitive repair at that time.
Okay. And unfortunately, Dr. Frisbee is not here, but in one of the conferences, he told us a long time ago, the operation was perfect, but the patient didn't do very well because it took too long. Anyhow,
Right.
So did you do any investigation of his leg to see if he did have deep vein thrombosis?
We did do ultrasounds. He did not have DVT. He did end up having a left IJ thrombus that was noted on ultrasound later.
So more than likely, this pulmonary embolism came from thrombosis of the upper extremity venous system rather than lower extremity venous system. Hence, the deployment of the IVC filter would be superfluous. Would I be correct in saying that?
That would be correct.
Right. So when I personally do not ligate axillary veins because I find my patients get enormous amount of swelling in the leg and they're miserable afterwards. I try very hard to repair or shunt or do something with it. Ligation is not in my forte. So in my opinion, I think the pulmonary embolism came from the upper extremity venous thrombosis rather than lower extremity. And the lungs are small because you have given him 30 units of blood. I think you will find if you take the lung out and weigh it, it'll be very heavy, laden with fluid, and hence you're seeing the picture like this. I don't believe this patient has any phrenic nerve injuries because the diaphragm on the right-hand side is visible and it looks in the right place as well. So I think what you have here is, in my opinion at least, that he has a collection of clotted blood at the apex of the right lung, and it is extending downwards. Your pigtail catheter has not done anything at all to drain that. And on top of that, he probably has a pneumonic consolidation in his lung. So you have a complex picture going on here. Thank you.
Thank you, Dr. Kasim. Dr. Azaz, you have a comment? Okay.
Thank you. Thank you.
Huh?
Actually, I totally agree with last comment of Dr. Kasim and previous comments from my colleague. Just in addition, I concern that wide mediastinum, and I don't know whether they put a tube after sternotomy or not, and might need echo or EFAS to see any collection in the mediastinum and in the pericardium. And actually, I would go for CT angio to study and see what is the cause of this issue. Thank you.
Thank you, sir. Dr. Marttos, comment before we return to Dr. Sumeet? Okay, back to you, Dr. Sumeet.
Yeah, no, good case. Everything is fine. So keep going, please.
Okay.
Oh, all right. Thank you, sir.
All right. So again, I appreciate all the comments. I think a lot of people noticed very quickly that the way that this was sort of layered, like the lung itself just looks like it was kind of being squeezed down. So this, so I'll show you the CT images in a second, but this did end up being an extrapleural hematoma. At the time, we did not, just because the proximity of this was that essentially he had a completely normal chest X-ray, before we removed a regular sized chest tube and removed the chest tube, and then he developed this huge hematoma. And the chest tube was, in the thoracic cavity, it wasn't near a graft. So we were less concerned about it being a graft like pseudoaneurysm or issue just based on the clinical picture, and given that he still retained palpable pulses. As far as the wide mediastinum, we were concerned about there being a possibility of of accumulation of some sort of fluid in that mediastinal space. He did have a drain initially. This had been removed by post-op day, 5 or 6, and so so we did do an ultrasound as well, and that ultrasound did not show any recurrence of any pericardial effusion. So this is so we decided to do a non-contrast CT scan based on that. And what you can see again, this is an extrapleural hematoma that does extend a little bit, medially, which explains a little bit of the widening as well. But the lung itself was spared. So his oxygenation had actually begun to improve. I think he had become a little bit more mobile. So at that point, we decided not to drain the extrapleural collection and just follow it with serial imaging to see if it was changing in size. This was actually his X-ray, about a week after that instance. You can see that actually on its own, the fluid seems to have resolved. So it may have been some component of hematoma and some component not. So basically for the rest of his hospital course, the subpleural hematoma essentially resolved. Like I said, the cultures had been positive for an MSSA pneumonia, and that slowly improved. And then he had a couple other minor issues. Neurosurgery was consulted for this brachial plexus injury, for which he's going to get outpatient EMG studies and such. And he also had a little bit of a vocal cord palsy from intubation trauma. He had a vocal cord granuloma, but this also did not really inhibit his ability to eat anything. So ultimately, he was able to be discharged on post-op day 20, 20 to go home, and has been doing pretty well since then. So just as kind of a real quick thing, I think there's a lot of different ways to approach chest trauma, of course. So I kind of posted the slide as a refresher for thoracic incisions. In this case, since we were talking about proximal control of the right subclavian, I think the median sternotomy didn't end up being the best approach, but obviously, depending on the situation, you know, in a coding patient, we may have started with an anterior lateral thoracotomy and proceeded to a clamshell, but he at least was maintaining his blood pressure when he initially showed up. And then, of course, for a left-sided injury, there have been, I think the left subclavian has always been a source of controversy in terms of approach, from descriptions of high anterior lateral thoracotomies to, you know, many believing that the median sternotomy is still the best approach to get proximal control, with extension to, you know, a potentially even trapdoor incision if needed to get control. So, you know, again, lots of different approaches. I think in this case, since we were trying to explore the pericardium and explore the right subclavian, the median sternotomy was very clearly the best incision to go to for that purpose. Or possible, you know, obviously at the time we didn't know whether it was a carotid injury or not either. So, so I thought that was the main kind of, you know, interesting point to this case. And then of course the subpleural hematoma, like a very, I would say, uncommon complication to develop, but in this case it ended up resolving without us really doing any other sort of intervention. So, so that's all I have. So I guess we'll go to final thoughts.
Yes, sir. Let's go to Ryder. Dr. Rattan, your final comments, please.
Yeah, that was a great case to meet, and a good outcome for sure. You know, I think that you approached it appropriately, and I'm glad you guys ended up not training that extrapleural collection. I don't know if I would have had that discipline, but it turned out for the best. I think with regard to your last slide, I found, not that I have done very many, but I've always found the trapdoor to be a disappointing amount, an increase of exposure, and hasn't helped quite as much as I would have hoped it would for the left subclavian. And then, you know, in terms of that high anterolateral thoracotomy, I'd love to hear what other people think, both about the trapdoor and that. We tend to lean away from it. Most of us, we actually did a poll recently this past week here at Ryder, and most of us tend to prefer the median sternotomy, even for access to the left subclavian. And I'd just be interested to hear what other people think in terms of experience. You know, we were able to acknowledge that the books all say high anterolateral, but in practice, I think we prefer the median sternotomy. So I'd love to hear what other thoughts are.
Thank you, Dr. Rattan. Dr. Ajaz?
Thank you. Actually, thank you for very good case and good save and good approach for the case. Thank you very much, actually.
Thank you, Dr. Ajaz. Dr. Kasim, your final comments, please.
It's a very good educational case, and I like to comment on the trapdoor incision. I have the same experience as my colleague from Miami. I'm not thrilled doing the trapdoor incision. I rather go median sternotomy and extend it anterolaterally to the left side, and I get to see what I want to see. Trapdoor incision also takes much longer time to do that. I have seen my colleagues do that, and they take a long time to get that accomplished in an emergency. Personally, I'm not very fond of that. If I do need yet another bigger exposure, I don't have any problem in removing the left clavicle, should that be necessary. I can do that pretty fast too. I think this is a very good case where we get carried away. Initially, we want to do the perfect thing, and then we get into trouble. I personally would have done the shunt on this patient, and then shunt the vein as well, put the patient on anticoagulation. That would be my approach, but of course I am quite cognizant of the fact other people would have a different thought on this. Excellent case, well managed. Thank you so much for educating us.
Thank you for your comments, Dr. Kasim. Iraq. Dr. Untrak, your final comments, please.
Yes, I have a question about the extrapleural hematoma. I take it if you thought that the hematoma was intrapleural, you definitely would have evacuated it to avoid a trapped lung later. But just refresh my memory, in what anatomic layer is this? Is it between the rib cage and the parietal pleura, or where anatomically is that hematoma?
Yeah, so we suspect it was between the rib cage and the parietal pleura, so kind of compressing the lung extrinsically from that, but not in danger of trapping the lung. And we thought it probably stemmed from muscle related to the chest tube placement, you know, in the context of anticoagulation, because you know, again, the context was essentially immediately after removal of that tube. It must have, you know, lacerated something on the way out or undid some sort of tamponade that it had, and that led to the extrapleural hematoma.
Okay. And how do you distinguish the two, intrapleural versus extrapleural, on the CT scan?
So so that's also a really good question. So I think a lot of it was, you know, one, we'd already tried placing a pigtail anyway, and that didn't work. I think the other part of it was when you look on the you know, obviously I only included one cut on the CAT scan, but when you look on the CAT scan, and a lot of it does with like the contouring of the hematoma, because it wasn't, you know, it was extending up in this way, which you wouldn't necessarily expect. And as you go down further in the cuts, you actually see it disappear, as if it was coming in, you know, so that led us to believe is more of an extrapleural hematoma as opposed to it being intrapleural, where we'd expect it to layer more and go all the way down to the bases in this patient. And so, you know, especially given that while he did have a chest tube on that side, he didn't have any major intrathoracic injury that would have caused like an early loculated effusion, or at least that we felt, again, given the timing of the situation. And, you know, again, on the x-ray too, you see this sort of the similar thing, which is that the way that it's contoured, the sort of like concave way that it is, and that it's restricted to this upper segment of the lung. You know, this was in the ICU as an AP film, but he was at least semi-upright for it. And so, so I would have expected more layering posterior, like, you know, posteriorly and inferiorly, as opposed to it kind of staying in this region, which, you know, the chest tube had basically come in like right around here. So, so a lot of it was kind of looking at the geometry of the effusion itself and also the clinical context. And then, you know, we also had the benefit of the fact that someone placed a pigtail, and that the pigtail was clearly intrapleural and didn't drain anything either. So
right.
between all of those things.
And there's no benefit to be gained by draining it, or is there a risk to going ahead to drain it, the loculated collection?
So I don't know that there's any like great data that when I was looking through on these, because I don't think they occur that commonly. You know, I guess the counterpoint would be, you know, is there a risk in terms of you know, infection of this collection, because you know, you had a chest tube that was in place that was connected to the outside world, and so, but that collection then developed immediately afterwards, but obviously it wasn't a completely sterile space. So I think that would have been my concern or I think that was our concern when we left it alone, was whether it would be more of an infected collection. And the other concern, I think, would be if it expanded and decreases lung volumes enough that he developed additional respiratory insufficiency, especially in the context of him having a significant amount of pulmonary edema, or, you know, transfusion-related lung reaction, that type of thing. We decided to leave it alone and follow serial x-rays in regards to expansion, so that if it did expand, then we would have to either, you know, do interventional radiology or operate on him, as was alluded to earlier. As far as infection, you know, same thing. We decided to, you know, try to leave it alone, and that if he got infected, then, you know, again, we would be forced to operate, but that we had some time, you know, he was still in the ICU at this point, and we were closely monitoring him, so we felt that if he started to develop signs of infection or sepsis, that we could intervene in a fairly timely manner. And so that's the reason that we decided to leave it alone. And ultimately, in this case,
yes, it's amazing that after 10 days, there's no sign on the chest x-ray that it was ever even there. It just, you know, it's a little unbelievable almost.
I was very surprised by that as well. But you could see it definitely slowly began to disappear over time. I don't know if it just redistributed into a sub-Q space as he was breathing better, because certainly in the same way that it was exerting pressure on his lung, you know, this was also the point when he was not as participatory and not breathing as deeply. I think it's entirely possible that if it was not bleeding, that it redistributed. He had a lot of soft tissue space that was in his chest wall, and so it's entirely possible it redistributed there as he was starting to get less pain and breathe better too. That's, I think, more likely than all the blood being absorbed within 10 days, because that just, I agree with you, that just seems impossible. So.
That the extent of your comments, Dr. Lindrak?
Yep, that's it.
Great, thank you very much. Dr. Ali in Trinidad, your final comments, sir.
Oh, no further comments. I was just surprised that 30 units of blood being required, as you know, where that 30 units came from. Is the density that was seen extrapleural, that accounts for 30 units of blood loss?
Well, so just keep in mind that extrapleural hematoma, that was more than a week after the initial operation. So when he initially presented, he did not have a hematoma in his right upper chest. So that 30 units of blood loss was purely from the axillary artery injury that had happened and the amount of time it took to get control and everything, or axillary artery and vein injury, I should say. So then he had the chest tube and he did not require any more bloods. And this hematoma, he did not require any blood either. Or it might have been like a unit at best. Like he did not end up needing a significant amount of blood products with the development of this hematoma. It was just more visual. But this was more than a week from his injury. So I think more of the pulmonary edema picture that he had was probably some remnant of the transfusions that he had from his original operation. But the extrapleural hematoma was not.
Thank you very much, Dr. Ali. Let's go to Dover. Dr. Alex, for your final comments, sir.
Yes, great, great case and presentation. I have some questions and a comment or two. So, with regards to the chest X-ray, it looked kind of odd that the fact that the base and the costophrenic angle on the right side did not fill up with this, retained fluid or blood. So, my question to you is, so axillary artery, there are like, 3 portions of the axillary artery. Which one do you think was stabbed? Because it looked like a pretty, big chunk of the artery missing. So, maybe one with more collaterals, and then you had some back bleeding after the graft was placed, and that caused the fluid accumulation. What are your thoughts on that?
So it was very proximal. It was basically the first section of the axillary artery that was injured. And so it's possible, although, so that would be the case, although if that was the case, again, it would have been tamponaded by, the chest tube was much lower, that had been originally placed in the operation. That was placed in sort of your classic fourth intercostal space in the OR. And this hematoma occurred immediately after the chest removal. So again, I think clinically, it seems to make more sense in context, because he did not develop this hematoma for like a week after the repair, at which point really, he then, unless he developed an infection, it would be unlikely, I think, for it to be related to a branch like that. So I don't think it was a branch. And then also it stopped and tamponaded pretty quickly, and he did not require any extra blood. I feel like if it was a branch, it probably would have been more significant in terms of that, but it's possible. I definitely can't say for sure. Again, we did a non-contrast CT scan because we may have had a little bit of tunnel vision as far as focusing on this whole timing with the chest tube and everything. So it's entirely possible that may have been something that we missed and that he got, and that he's lucky. But I think the likelihood was pretty low for that.
What's your follow-up plan for this patient, and any antiplatelets upon discharge for the graft, or anything else?
So good question. In terms of follow-up, we had him on therapeutic anticoagulation because he had the pulmonary embolism. But I think after that, antiplatelet therapy would definitely be beneficial for him. It's a 6 millimeter graft. It's not super small, but it is certainly a higher risk, especially as it's a prosthetic material. And then we are planning on seeing him back in clinic for follow-up with regards to vascular injury. I think he'll get, we'll probably do I'll have to check if we planned on doing a CTA or a duplex. I think given how proximal it is, it may end up having to be a CT scan to check on the patency of the graft, you know, in like a month, and make sure that that's still going. And then the other thing that he needs is outpatient follow-up with neurosurgery for the brachial plexus injury. So he's going to get EMG studies and things like that, because he still has some weakness and sensory deficit in his arm. So.
Well, with regards to your slide with the different incisions and you know, question about, you know, kind of approach for the left subclavian. So basically, I think a trapdoor is a difficult, cumbersome way to, you know, expose that. I think a combination of you know, also from teaching acid median sternotomy with a supraclavicular approach, plus or minus excising the clavicle, it gives you enough for the left subclavian artery. I think, you know, and the kind of trapper type incision where, let's say you have the arresting patient who exsanguinated, and then you do your left anterolateral thoracotomy, you're lower than, you know, would give you good access to the subclavian, and then you go to the operating room, like you brought the patient back, you know, as you're kind of trying maybe with a sponge stick to kind of tamponade in the left apex of the left chest to control the bleeding, and then you go in the OR and you do your median sternotomy on the left supraclavicular. These are my comments on the incision slide. Great case. Thank you so much.
Thank you, Dr. Alex. Let's go to Sao Paulo. Dr. Calais, for your final comments, sir.
Yes, I agree with all comments. I give congratulations for the case. I have one comment that is very interesting, because subclavian artery and axillary artery, you have different access from the left and the right. And for the right, if you know that the incision, there is only a subclavian transition for the axillary artery, for the subclavian for axillary artery, you needn't go to a thoracotomy. You can go only local access. You can go a supraclavicular access on the right side. You can section the brachiocephalic trunk near the sternocleidomastoid muscles, and then you can control the proximal subclavian artery. If you need, you can resect portions of the clavicular, or you can only go the size and infraclavicular and axillary section on the arm. So it's not difficult to do and avoid a thoracotomy in this situation, because if the patient is unstable, can go to control. The thoracotomy is much easy to control the access, but the surrounds of the artery on the right side or the left side. But try to avoid these incisions for treat axillary or subclavicular artery. On the left side, either, if the transition of the subclavian artery from the axillary from the subclavian for axillary artery, you can approach by supraclavicular incision and avoid the thoracotomy. If you need to go to surrounds of subclavian artery, you can use a sternotomy and go association with a supraclavicular incision. You can find easy the axillary artery, because you can see first the carotida, and then on more DP you can see the surrounds of the subclavian artery. Sometimes I make some dissections, because I have sometimes to make section of the neck for students to see the vascular to put the venous access. I know these incisions can be easy to do. So I believe that sometimes you can avoid thoracotomy. In patients with bigger patients, you can make problem on the chest, ventilation, and other problems can be association with the thoracotomy. Sometimes if you can know before the surgery, where is the surrounds? If you can avoid thoracotomy, maybe a nice idea. Congratulations for the case, excellent case, and thank you for the presentation.
Thank you, Dr. Calais. And Dr. Kasim, I'm in agreement with you. Your sunrise is beautiful, by the way.
Thank you.
Yeah, let's go to Bangkok to Dr. Supa. Your final comments, please.
Thank you very much for presenting this case. The case is very interesting and very academic. Regarding the left subclavian, I agree with comments. In my experience, I usually use a clavicular incision first to try to control the bleeding. And like Dr. Kasim mentioned, I will not hesitate to take off the left clavicle to gain more exposure. If I cannot see the original bleeding, the next step is median stenotomy. Median stenotomy can give you additional exposure of the proximal subclavian, but not to the origin of the vessel. And lastly, if I cannot obtain the proximal control, I will not hesitate to extend to trapdoor incision. Although this incision is very morbid, but it can be life-saving in some situations. Thank you very much for the case and the learning points.